Hello, everybody. We should get started on healthcare sustainability. I would like to call on the first speaker and session moderator. I believe it is Pallavi or Leila.
Hi, this is Maria Zlotnick from UCSF. I'd like to introduce Pallavi Mellon, who is at the University of Pennsylvania, who will be moderating our session on sustainable healthcare.
Thanks so much. So I guess we can go ahead and get started. So before I introduce our speakers for today, I'd like to contextualize the session a little bit with a brief overview of the impact of healthcare on the environment. So let me know if you can't see my slides at any point. So to understand healthcare's footprint numerically, the climate footprint of healthcare is equivalent to about 4.4% of global net emissions. So that's about 514 coal-fired power plants. And the top three emitters are the United States, China, and the countries of the EU, which make up about half of the world's total healthcare climate footprint. So there are three possible scopes when considering the sources of environmental emissions. So scope one are emissions directly from healthcare facilities and healthcare-owned vehicles. Scope two would be more indirect emissions from purchased energy sources like electricity, steam, cooling, and heating. And finally, scope three, which is where most of our emissions actually come from, are from the healthcare supply chain. So that could be the production, transport, or disposal of goods and services. So to quantify this a little more, in 2014, the US spent $5.9 billion on medical waste management. So looking ahead, this is really where we need to focus our efforts on the healthcare sector, kind of taking more responsibility for its climate footprint through strategies like waste management or less single-use items and decreased emissions. So with that, I'd like to introduce our speakers for today who will give us a better idea about healthcare sustainability. So each of our speakers today have experience at different organizational levels. To start, we will have Ms. Steffi Barna from the UK Centre for Sustainable Healthcare talking about more national level interventions. Then to understand hospital interventions, we will hear from doctors Katie Lichter and Claire Baniel from UCSF and Stanford respectively, as well as Dr. David Barnes from UC Davis. And finally, to understand student level interventions, we will hear from Ms. Leila Farshidpour from UC Davis. As a reminder to our presenters, Dr. Zlotnick and I will notify you if you exceed your allotted time, because we want to ensure that we have time for discussion at the end. So thanks again to everyone for being here today. And with that, I will hand it over to Ms. Barna to get us started.
Good evening, good afternoon, everyone. Are you able to see those slides?
Yes, we can.
Yep.
Okay, great. Well, I'm dialing in from Oxford, England, and it's 9 p.m. So very happy to meet you on a Friday evening, and wanted to just share a few things that they've been doing in England around system-wide triple bottom line of sustainable healthcare. So as Pallavi mentioned, the NHS has committed to measuring its scope 1, scope 2, and scope 3 emissions with a very ambitious plan to reach net zero earlier than many other policies, government policies had been here. And if you're able to see on the left the examples of the direct and indirect emissions, what I thought I'd talk about today is some of the ways that we're thinking of doing that. So this is a little bit of a complex graph, but basically the purple images in the top show us the wedges that we need of carbon reduction in order to get to that goal. And the purple ones are sort of your national energy supply, things which the health system doesn't really have direct control over. So, you know, switching to renewable energy. The sections under that are very often seen as things that clinicians do have control over. And then under the clinical sections in the sort of gray area is the infrastructure, the buildings, the facilities, which is what most people think of when they think about making changes for increased sustainability. And of course, at the bottom, you can see quite a large wedge where we're not really sure what we can do. And so again, it's very important for clinicians to be involved in figuring out in their settings, which they know very well, what's the best way to reduce their carbon emissions in that area. And the one other point I wanted to make on this graph is you can see on the left, the black line that sort of goes up and down. So that is essentially the carbon emissions of the National Health Service over time. So you can see that emissions started going down quite early. And that is really just because we had a government that cut funding to the National Health Service. So you can achieve carbon emissions by providing less healthcare, but that's not the ideal for us. We would really like to provide less healthcare because people are less ill and not just because we're cutting budgets. So that's really what the challenge is to think about sustainable value. What is value in a health system? Well, ideally, we would think about not just the outcomes for patients over the cost, but we think about outcomes for patients and populations over this triple bottom line of financial cost, environmental cost, and social cost or benefit. So I'll just give an example of how we've been thinking about it in England. If you look at this driver diagram on the left, you can see we would like to improve population health or the individual patient's health while reducing carbon emissions. And there are two ways to do that. I'll start with the bottom because that's what people usually think of. So we can reduce the carbon intensity of what we do. And at the very bottom on the right column, you can see we can, make facilities more lower carbon. We can swap some of the things we do. We can change our anesthetic gases or our inhalers, so a low carbon alternative. But the top three boxes are actually much more powerful. If we have lean care pathways, if we empower patients to understand their condition and take care of it, and of course, most importantly, if we can keep people out of hospitals altogether, all those carbon emissions, all that cost, all that patient suffering, all the extra staffing needed will be avoided. So what we've been doing is thinking in each of the medical specialties, in the allied health professions, in the nursing specialties, where are your carbon hotspots? Where can you intervene in these areas? What would be your easy wins? And so we've been running a number of programs looking at, this integrating sustainability into quality improvement through running competitions where we bring people together from different teams and wards in hospitals to come up with ideas, measure the triple bottom line, and then look at the improvements. So very often in that process, people will come with a nice small idea, like let's have double-sided printing, and they end up with early patient discharge led by nurses. So you've got people leaving the hospital sooner, patients are happier, staff are happier, obviously money is saved and carbon is saved. I would encourage anybody who's interested in one of the medical specialties to join one of our networks. Those are thousands of people connecting with each other, posting, we're trying to do this in my hospital. Has anybody tried this before? And those are basically peer-led networks where you can post articles, ask questions. We've been running really short courses in CPD to help bring people together, clinicians, and say, in nephrology or in mental health or in primary care, what techniques do we know are there? How do you use them? How do you implement them? And again, with peer networking, sort of movement building. So if I've got a couple of minutes, Pallavi, I just thought I'd give an example of the kind of project that people come up with that has a triple bottom line. So one emergency department said everybody gets cannulated when they come in. Many of those are not used. So they did a regular QI process, studied the system, looked at the environmental costs, social costs, and financial cost of various choices along the way, and then costed out how much they saved, what the various improvements were, and then rolled that out across a series of hospitals. So I think I just wanted to say these processes are all available on our website for free. The quality improvement step-by-step guides and teaching packs are all available. So if you have a look at the website, you might get some ideas, and we would welcome questions or working with anybody. Thank you.
Thanks so much, Ms. Barna, especially for taking this time at this late an hour on a Friday evening. So for our attendees, feel free to put in questions in the chat, and we'll get to them after all the speakers are done. So next up, we'll hear from Drs. Lichter and Baniel on a 6-minute waste audit toolkit, whenever you're ready.
Great, thanks for the introduction. And everybody can see my screen in our presentation. Fantastic. Yes. Well, thank you and good afternoon. Much appreciate the Symposium student and faculty leaders for the opportunity to talk about our experiences as trainees and residents in engaging faculty and staff on sustainability projects from a departmental level. As we all know, trainees can be quite busy with clinical demands. So the two of us are very excited to share this 6-minute initiative and hope to lower the threshold for others to perform similar audits in their own departments. So on that note, I will hand it over to my co-collaborator, Dr. Claire Baniel from Stanford.
Hi, everyone. Thanks so much, Katie, for the introduction. So we're very excited to talk with you all today about our experience leading a clinician and resident-led project to reduce medical waste. So as we've heard throughout the day today, climate change presents a tremendous public health opportunity for hospital systems to work together to improve patient health. One major area for opportunity is reducing procedural waste. The U.S. healthcare system is responsible for nearly 10% of national greenhouse gases, as we've heard today. And over 2/3 of those emissions are generated as a byproduct of the medical supply chain. This includes product acquisition, transportation, and waste disposal. And in fact, as you see here, a single hospital bed actually represents and generates 29 pounds of waste per day. If you consider that across over 6,000 hospitals in the United States, this amounts to over 5 million tons of healthcare associated waste generated each year. And this is also costly, representing over $10 billion spent annually on disposal costs related to healthcare associated waste. Next slide, please. So we began to ask ourselves, where can we start and how can we reduce our medical waste? So it's important to note that life cycle analysis, which are comprehensive assessments of the entire system's process from manufacturing through disposal, are the gold standards for quantifying waste associated with a certain process. However, for busy resource-limited clinical practices and as resident physicians, we found that these are not always feasible to achieve with the resources that we have. So with this in mind, we began to think, how can we look at our current processes and make changes now? The most natural place for us to start was within our procedural department and specifically within our brachytherapy suite. And to validate and sort of guide our experience, we looked towards quality improvement methods such as A3 modeling and root cause analysis, which we'll talk about more today. So what is a waste audit? This is a quality improvement process by which we looked at our current practices and standards and supply usage within our department to start to quantify what sort of waste we are generating and exactly where it was going and how it was being disposed of. So all of the steps we'll talk about here today is easy to achieve in your own department using a team as shown assembled here, which represented resident physicians, attendings, medical students, nurses, tech staff, involved limited supplies. So we were able to use a clipboard and a printout piece of paper to describe the waste that we were generating, as well as a waste scale to actually weigh these. And then we filled out the worksheet that's shown here at the right to categorize our waste, such as biohazardous and non-biohazardous waste, as well as reusable items that were being used. When we actually kind of dove into what was being generated, next slide, please. We were able to take photos as shown here. So the photo at the left shows a typical procedural setup involving both reusable materials as shown as the pictures at the top, as well as single-use disposable materials at the bottom. We found that over the course of the procedure, the biohazardous waste is being represented at the top with that red bag shown there, And then we also took photos of the non-biohazardous waste just so we could have a bit of a qualitative image of what the waste actually was we were looking at. All the data we collected on the worksheets was then put into a Google Drive and a spreadsheet that the whole team members had access to and could analyze throughout the process. And most importantly, we found that this entire process took only about 6 minutes to conduct the audit with filling out the worksheet and taking photos. So minimally descriptive of our clinic process. We then took all of the sheets and Excel files and were able to create a run chart looking at our baseline waste usage. And then qualitatively, we were also able to look at all the photographs to identify areas for maximum improvement. When we started looking at the data, we realized that biohazardous waste and specifically reduction presented a tremendous opportunity, both in terms of cost savings and proper allocation of waste spreading within biohazardous and non-biohazardous. So that's what we set as our SMART goal to achieve in our department here. As we really dug into each of these components in specific, we really focused on 4 main principles to guide our discussions, and that was reducing waste, looking toward reusable materials as alternatives, recycling where possible, but also we found that we were really rethinking the way that we were looking at these standard procedures that we were doing in radiation oncology. And a huge part of this also was increasing stakeholder engagement. We found that a lot of our nurses were actually very involved and had a lot of important insight because they were involved with all of these procedures closely. Next slide, please. An exciting thing that we found was that not only was reducing biohazardous waste important for our team and for our system operationally, it also was cost savings. So we were able to look at what our costs were associated with solid waste disposal, with recycling process, and then medical and hazardous waste in specific. And we found the cost of disposing biohazardous waste was significantly higher in comparison with recycling materials and even just standard landfill waste. These important conversations really helped guide our discussions with our department leadership in prioritizing these changes. And then I'll turn it over to Katie.
Yeah, and so then as Claire mentioned, what we were really excited about was how simple it was to conduct this audit. So as she mentioned, each time we did data collection, it took an average of 6 minutes to conduct. It took less than a year in total to get baseline, establish goals, and then reassess. It was a fantastic team building exercise, but also it saved money. So we asked ourselves, if we can do this, why not others? And so that's why we established actually a brachytherapy waste audit toolkit. And when we designed this, we designed it certainly tailored to brachytherapy, but with the goal of it actually being a procedural waste audit. So for others to take and adapt to the procedures that they do in their department. So our waste audit toolkit right now is publicly housed, available for anybody to use. And then we actually created 2 versions of the toolkit. So one is a year-long project, and this is really ideal for resident quality improvement projects. As we've highlighted, it can be tough to do these projects. And so actually at UCSF and Stanford, residents are required to do a year-long QI project. And so this is a great way to actually get credit for this. So then within this year-long waste audit, there's actually modules that are housed in there for best practices in performing both QI and sustainability QI projects. And then the second one is just a simple waste audit, and this is good for small teams. So certainly, good for large academic centers, but all the way down to those in community practice. We had a lot of radiation oncologists who do these procedures in the community, and we're also looking to have this good team building exercise. Within the waste audit toolkits, each one has an overview, helpful tools for setting a timeline, project templates, and instructions to guide you through each phase of the waste audit. So next steps is dissemination. So we've been really excited. The first waste audit was at Stanford in their radiation oncology department. Then we established the toolkit off of this experience and then transferred it over to UCSF and have been doing a waste audit there as well. And the really unique thing is that each department or, each place will have totally different results. And so finding what's unique to the department, is really key on settling in on best practices in order to reduce waste and increase sustainability. And then our ask here is, encouraging everybody to think about who is next. So again, this isn't tailored to simply radiation oncology, but really trying to have a toolkit that can be adapted to all procedures, really lowering the inertia. And lastly, we recognize that not everybody has the time or capacity to do a waste audit within their department, but especially for the residents who may be joining us today, that there's opportunities to be a leader in sustainability and spur change in other ways in the department, and encourage other people to look at other things, whether it's in a procedure and thinking about using only necessary supplies, or if it's other things in the clinic, such as, being mindful about what goes in the red bag waste, the biohazardous bags, or even choosing to do telehealth visits when necessary. So we thank you for the opportunity to talk today, and to all of our team members at both UCSF and Stanford who have helped us in getting this going. And then we leave you with both of our emails because we're really excited to collaborate with others across all institutions and see where else we might be able to implement this. Thank you.
Perfect. Thanks so much, Drs. Lichter and Baniel. Very interesting. I'm sure we'll have some questions at the end for that too. So next up, I'd like to invite Dr. Barnes to provide an overview of the Sustainability CQI program at UC Davis.
Thank you. Should I share my screen or are the slides provided?
You can go ahead and share your screen.
Okay. Can you see that?
Yep.
Great. Thanks everyone, and thanks for inviting me to share for just a couple of minutes about the GME high value competition and the new or relatively new sustainability category that was added last year. My name is David Barnes. I'm one of the medical directors for the Department of Emergency Medicine and unofficially the physician champion for sustainability in the Department of Emergency Medicine. So a little bit of background, the GME High Value Competition is an annual grant competition that's funded by the medical center. This was conceived several years ago by our Chief Quality Officer. And the intent of the high value competition is to really support residency programs and fellowship programs to build quality improvement curriculum. It encourages learners in GME, fellows and residents to participate in quality improvement initiatives, especially in a large academic center like UC Davis, where trainees make up a substantial portion of the clinical workforce. The hospital provides seed money for projects, and the culture of the competition really is intended to cultivate future leaders in healthcare quality and systems innovation, to develop and promote a culture of safety and quality at the trainee level that then spreads throughout the institution. And there is an education component about educating trainees about quality, safety, and the UC Davis Medical Center value construct, which focuses on the patient experience, quality and safety, and financial stewardship. Now, missing from this equation, we recognized sustainability was an important piece of that we could add, with the understanding that climate change negatively impacts health, that sustainability initiatives are integral to improving healthcare with reducing energy, reducing consumption, waste, and pollution, and how that could be cost effective and beneficial to the climate and the planet. We recognize that there was an opportunity here. So the UC Davis Health Sustainability Advocates conceived this idea of adding a sustainability category to the GME high value competition and approached hospital administration, who was very receptive, and primarily because this concept aligns with UC's commitment to carbon neutrality, as well as the UC Davis Health Value construct. Our hope was that by acting locally, we could make large changes that could be scaled to the health system level to address climate-induced healthcare challenges. The sustainability category really mirrors what the basic high-value competition grants, how they are structured. So there are 4 sustainability proposal awards given each year at either 18 or 36-month intervals, $7,000 each for a total of $28,000. The projects that are selected receive project management support from the Chief Quality Officer's office and analytical support as well from the health system, like building EMR reports, regular data collection and extraction. In addition, at the at the UC Davis Quality Forum, which is an annual expose of quality and safety projects throughout the entire health system, School of Medicine, School of Nursing, School of Public Health, etc. There are awards for the top 3 high-value competition projects that are given grand prize of $8,000, $5,000 for second prize, and $3,000 for third prize. Now, this is across the entire high-value competition, and because we're in our first cycle of sustainability awards, no prizes have been awarded yet in that category. The idea behind this is that successful projects could then be scaled to the system level so that those changes or interventions could be mirrored and expanded in other areas of the healthcare system. The funds awarded for either the proposals or for the final awards can go towards supporting project development, hiring additional staff, sending trainees to conferences to help develop them professionally, scaling the project throughout the system, or building and supporting quality improvement curricula for the program. And then finally, just some examples of the 3 projects that were funded this year. The winning project was minimizing silicone dressing use in spine surgery to reduce operating room waste and cost. Project near and dear to my heart was also funded out of the emergency department, Going Greener Than Sac State, Sustainability in the UC Davis Emergency Department, which focuses on reducing or even eliminating paper waste in the ED through the use of electronic prescribing, double-sided printing, and electronic after-visit summaries. And finally, healthcare and environmental sustainability, alleviating the burden of inappropriate culturing and processing on the environment. We hope to have a lot more projects that are submitted this year and look forward to many of them being funded. Thanks for the opportunity to present, and I'm happy to answer any questions, or you can contact me by email.
Thanks so much, Dr. Barnes. So finally, we will hear from Ms. Farshadpour on reducing unnecessary urine cultures.
Sorry, guys. Give me 1 second. Are you all able to see my screen okay?
We can, yes.
Yep, you're good.
So hi everyone, my name is Layla Farshadpour. I'm a 4th year medical student at UC Davis. Thank you so much for having me, and thank you all for being here today. So today I'm going to be speaking to you about reducing unnecessary urine cultures in the hospital system. So hospitals every year generate hundreds of millions of tons of waste every year. That waste comes in many different shapes and forms. There's non-hazardous waste, there's hazardous waste, there's waste in the form of energy, there's pharmaceutical waste. And oftentimes we think of waste from the healthcare system being hazardous and therefore difficult to dispose, but actually more than 70% of the health system's greenhouse gas emissions and waste are embedded in the products and services that they buy. So how do we address this problem? This is a very big problem. It is a problem that affects healthcare systems all throughout the country and the world. And there's a lot of different angles from which we can tackle this. It's possible to be involved in grassroots efforts, such as through community engagement within your institution, within your communities. It's possible to do so through top-down policy or through education initiatives. But at least for me, I think it's important to first understand the problem, and that brings to mind research. Now, in medicine, we love research, and some areas are more well researched than others. But unfortunately, when it comes to the intersection of healthcare and sustainability, there isn't a lot of really good data out there. And so I, along with my group, decided to look at urine culture waste at UC Davis and the problem of unnecessary urine cultures that are done. So according to the literature, 58 to 68% of urine cultures that are done at hospital systems are not clinically indicated. A lot of different effects of inappropriate urine cultures have been studied. And so people have looked at length of hospital stay, they've looked at issues with antibiotic stewardship, as well as excess healthcare costs. But unfortunately, there haven't been too many studies that have investigated the subsequent impact of unnecessary urine cultures on the environment. So not only do ordering unnecessary urine cultures lead to unnecessary waste and costs, but they also lead to harm to patients in the form of antimicrobial overuse and resistance, because we're treating patients that don't need to be treated. So just as a quick review for those who aren't really familiar with the indications for urine culture, these indications are split into individuals who are symptomatic and individuals who are not symptomatic. So people who present with symptoms such as urgency, dysuria, flank pain, hematuria, individuals who present with fever of unknown origin, those who present, especially in our elderly population, with altered mental status without another cause, or patients who are coming in with increased spasticity or sense of unease in the setting of a spinal cord injury, are all indicated to get urine cultures. There are select patients who we also get urine cultures on who are asymptomatic, and that includes individuals who are about to undergo a urologic procedure or individuals who are pregnant. So in our study, we retrospectively reviewed the charts of over 5,000 patients who presented to a outpatient to a UC Davis clinic between January 2022 and April 2022. 5,520 of these patients met our study criteria. The patients that were excluded because they were part of a clinical trial. And we looked at their chief complaints, the indication for why they had a urine culture done, whether they were pregnant or not, their associated diagnoses for the visit, and their temperature to determine whether or not a urine culture is actually indicated. We also weighed the plastic components that go into getting a urine culture done. These include the culture plates, the sample collection cups, as well as the biohazard bags. And then we used all of that data to calculate how many tons of plastic waste is generated due to unnecessary cultures at UC Davis per year. Okay. So surprisingly, our numbers actually look a lot better than a lot of the numbers that were presented in the literature. So according to our review, 36% of patients who presented outpatient at UC Davis had a urine culture done that was not indicated by chart review. Of those patients, 301 of them were started on antibiotics. And in terms of the fiscal cost of this, each urine culture costs our hospital system about $35 to do, which means that a little over $200,000 a year is wasted annually in getting these urine cultures that aren't necessarily indicated. In terms of the environmental costs of this, each urine culture generates about 180 to 360 grams of plastic. And that means just our outpatient population at one institution in the country is generating 1.5 to 3 tons of unnecessary plastic waste each year. So what do we want to do with this data now that we have it? So our goal is to identify regions within the hospital system and the specific clinics that have the greatest percentage of inappropriate cultures. Our hope is to investigate the cause of why this is happening, and then develop waste mitigation techniques. So things that have been tried at various other hospitals are things such as physician education or changes to the EMR that we can pursue. And then our goal is to repeat our analysis after our intervention to assess the impact. And if this project is successful, we hope to replicate this with other body site cultures that are oftentimes also done when they are not indicated. So just an overview of some take-home points from this project. I think it's really important to note that how we practice and improve patient care will also improve sustainability inherently. And so ordering unnecessary urine cultures has several costs to both the healthcare system and patients. The first is that it increases antibiotic resistance, it causes antibiotic overuse, and the risk of side effects that patients would otherwise not have. There's also a fiscal cost, and so there's a cost to the healthcare system, but also potentially more importantly to our patients who are paying for these tests that we're ordering. And then of course, the environmental costs of running these tests and doing these tests that is harming our planet and our patients in the long run. Thank you so much for your time.
Thanks so much, Ms. Farshidpour. So with that, we will move on to the discussion section of our session today. So we have a couple questions in the chat. So the first question directed towards Drs. Lichter and Baniel from Dr. Todd Sack. In the US, hospitals are responsible for only 36% of the healthcare sector's direct greenhouse gases. Our clinics and practices are close behind at 26%. What tools are there for practicing physicians to make an impact in their own offices?
Claire, do you want to take this or do you want me to take it?
Yeah, I mean, I think I can speak a little bit just from like the waste perspective. I think there's kind of multi-pronged approach for this, and that's what's so exciting for us, I think, looking at all of these different projects and opportunities. But reducing waste, I think, is one of the kind of low-hanging pieces, just because it's something that's simple to look at, feasible both in community or academic setting with large or small teams. We've also talked a lot as kind of a working group. So Katie actually founded a group within radiation oncology that is focused on healthcare sustainability that is represented by residents across the country. And another topic we've discussed is the utility of telehealth, as was kind of brought up at the end of our talk, but just identifying opportunities for seamlessly integrating telehealth, understanding that not all patient visits are appropriate for telehealth, but that's an opportunity to cut back on travel-related emissions as well. Katie, I don't know if you want to add anything.
Yeah, and I think it's really important to understand your scope of influence when you're thinking about it. So, there's always, radiation oncology is very small, but we said, that's okay, why not start there? And I think having the discussion is the most important thing. And then you can start to build out from there. So certainly, yes, waste is part of it. But also when you look at it, supply and supply chain is huge. And so starting with a waste audit really allows you to start to think about what supplies are we using and how do we make contact with our suppliers, and who is responsible for that at UCSF and in our department. And I think it allows you to work up the chain, looking at the inputs of all the actions that are happening in the clinic and start to address those things. And then, certainly you can look at pharmaceuticals. You can also, look at telehealth. It's been very interesting, within our department, we thought it was going to be our machines that use so much energy, but starting down these process, we did see that it's actually the patient and staff travel that is accounting for most of our carbon, footprint. And so where there are opportunities as physicians or as trainees to advocate for telehealth when it's necessary. Certainly, with an asterisk on there, it's not always necessary. And so I think that's been really exciting for us. And with that, we've actually been able to grow the network of people who are interested because, for example, telehealth, you start realizing that it's an issue of equity and access. And so going down those pathways, or, how can we look at conference travel in our department? So I think there's a lot of different areas, and I think we should never sell ourselves short by saying we can't, attack the biggest chunk of the pie, but every little slice starts to add up.
Perfect, thank you. And our next question is for Ms. Farshidpour. So what kind of barriers do you think exist in changing attitudes or the mindset of nurses or physicians to decrease unnecessary urine cultures?
I think a lot of times, partially, I think a lot of times people are just more set in their ways. And also in terms of taking the time to be more educated or kind of change practice styles. It's, I think, oftentimes like a battle to have people do that. And then I also think that there just isn't a lot of good research to know exactly where those barriers are. So I think it's really important to identify like why this is happening in order to be able to solve the issue.
Perfect, thank you. And our next question is more of an open question to our panelists, so feel free to jump in. So this is from Dr. Amanda Milstein. To build on Todd's question above, I'd love to hear ideas and tools for sustainability or decarbonization in community and non-hospital affiliated outpatient clinics, and would also encourage people to check out mygreendoctor.org.
I guess maybe jumping in a little bit for this one. This is something that interests me too. My background, I'm from northern Wisconsin. I'm from a very rural place, and most of my experience with healthcare growing up was small community practices and not large academic centers. And so this is definitely something of interest that we're starting to think about too. I think a lot of the principles we've discussed are even more pertinent for our community practices, especially being from a rural place myself. I know telehealth was something that we've discussed quite frequently because from a lot of rural places, you live far away from healthcare. So not only is reducing transportation important for carbon emissions and environmental footprint, but access to care. And that's kind of getting at what Katie mentioned, that a lot of environmental interventions are also equity interventions and helping to expand access to care for patients. So that's definitely one avenue where I think our communities actually are, our community physicians and providers and teams offer such a great opportunity to think about these problems because they're really at the front lines. Similarly, waste interventions, things like that, of course, would be applicable in a community setting, but recognizing that resources might be more limited. So quality improvement structured projects, I think, are a great chance for teams that are smaller, just because some of the life cycle analyses and larger scale analysis do require more time, more people, more funding, those sorts of things. So great opportunities there.
And then I would just echo the plug for My Green Doctor, great resource. That also really lowers the threshold and the barriers to engaging clinics. And I think the other thing for community clinics is sometimes even before implementation is simply engaging the stakeholders, the patients and the community members themselves, and understanding what's needed and how they're affected. And we've been working on wildfire projects, looking at radiation oncology centers way up north. And what we're finding looks, of course, very different than at UCSF and Stanford. And I think some of the most sustainability initiatives are those in which, stakeholders are engaged. And so I think sometimes actually even just surveying and understanding the patient population is, sometimes we forget the most simple steps.
Thank you. So our next question is for both Dr. Barnes and Drs. Baniel and Lichter. It seems like projects to decrease healthcare waste often save money, but need seed funding or admin help to get going. How can institutions help with this?
And I'll pop in for Dr. Barnes because he had to pop off. But I think the Davis program is really exciting. At UCSF, we have a similar program for the residents and other trainees centered around improving the quality of care. So trainees can propose projects and then receive assistance and get money in their own paycheck if they meet their quality goals. So a similar sort of project, but it hasn't had that sustainability focus that the Davis program has. And I don't know, Layla, if you have any insight into how well you feel like that program helped you, but it seems like, we all kind of we see things in our daily practice where, hey, we're wasting things, is there a way we could do this better? Or, I see my colleagues doing this care that I know is considered by our national body to be low value care. How can we make things better? And it seems like having that administrative help or a little seed funding could really get things off the ground.
I definitely agree. I think in terms of, so for instance, for our project, we looked over 5,000 patient charts, which is definitely not an easy feat to do if you don't have the administrative or the stats support. So it probably would have been almost next to impossible to do a project on this scale. And especially if we want to expand this and look more at inpatient, or if we want to look more at different kind of culture styles, so like respiratory cultures, for instance, it's really important to have that kind of support from the administration.
It would be great to see you take this project, Layla, to wherever you do your residency. Because obviously this sort of thing is probably easy to transfer to any institution. And so having sort of your know-how of how to get it done would be great. Claire or Katie, do you have anything to add?
I think just kind of branching off that it's okay to start small. Like with our department, we really, it was like me and I found an attending who I convinced and was crazy enough to like start looking at these questions. And from there, we've completely snowballed to involving an undergraduate student who had an interest and identified, support by leadership. And now, even just most recently, I had a meeting the other week with some of the Stanford Healthcare Administration because they're very interested in this now. So even if it feels small in the beginning, there's so much potential for growth. So encourage, any efforts, even if there's no funding up front, like those things will come.
Thank you. We probably have time for maybe one or two more questions. So the next one is for Ms. Farshadpour. Which regions of the hospital do you suspect have the highest percentage of inappropriate cultures, and why do you think this happens?
So what I've seen in the literature is, I believe in the emergency department, 35% of cultures that aren't really indicated or ordered there. I want to go into EM personally, and so that was definitely an interesting statistic to see. But I think it's hard sometimes when you are dealing with so many patients at the same time, and they are coming in completely undifferentiated, with a fever or just altered, and so you kind of cast a wider net without having time to really think about, oh, like, is this indicated, is this not? I think that's where like EMR checkpoints really come into play, in terms of making sure that we're doing things that are truly indicated for our patients.
Perfect. Thank you. And this is, again, more of an open question. So why is it important specifically to decrease biohazard waste? Maybe Drs. Baniel and Dr. Lichter, if you want to get started.
Dr. Lichter, do you want to take this one? I think we were just talking about this morning.
Yeah, absolutely. So this is something that we didn't know until we started down the waste audit track. And so red bag waste actually the disposal process looks very different than our normal trash, non-biohazardous waste. So because of what's in there, the contents, it actually has to go through a very different process. That actually looks different at every single hospital. But what we do know consistently, and there's good studies, can share it in the chats too, about what that looks like. And it's on average is one, it's more expensive, so interesting to hospitals. And two, it does have a significantly higher environmental impact. One of the stories I always tell is it's interesting if you start following and asking, how does your hospital get rid of its red bag waste? Some places it actually has to entirely leave the state. And so we think about the transportation emissions that are related with that, leave the state, go to a processing facility there, be treated, and then may in fact come back to the state. And so there's along the whole process, and there's LCAs where it really, maps out everything. But there's a higher environmental impact associated with the disposal of this. And again, also has a higher cost because you're going through those additional steps. And so that's where we found that if you appropriately put the correct items in red bag and then put everything else that's supposed to go into trash, that you can significantly reduce your environmental impact. I can find some of those links. And then I see a question here too. I can punt this one to Claire. So it's about the waste audits and how we were able to quantify the components of waste collected for further analysis.
Oh, sure, no problem. So it was kind of twofold because we appreciated up front that though there were some objective measures such as weight that would be easy to quantify in terms of how each were being sorted into biohazardous, non-biohazardous. We even looked at, we had a separate anesthesia trash can because our brachytherapy procedures involve general anesthesia. So there was additional waste receptacles associated with that. That was kind of easy to look at, weight measurement, but actually something that was incredibly important in reducing our waste was the qualitative data in terms of looking through photographs and even just what was comprising each waste bag. And for instance, one of the interventions that we are undergoing is our patients are positioned using single-use foam, large volume pillows that are disposed after each procedure. They made up probably 30% of the volume of the waste that we were generating. Though it wasn't biohazard, it still was significant contribution. So one intervention that we've enacted is replacing those with reusable gel pillows that can be sanitized after each procedure. And that in itself has significantly cut back on the volume of waste that we're generating. So just as important as the quantitative data has been the qualitative analyses that we've done.
And I would just echo that. Similarly, some of that qualitative data and the photos have been very helpful because when we come back together as a team, we can look at what is each component of the procedure and are there opportunities for intervention. So like as Claire said, some of the things that maybe don't weigh the most and we're not going into red bags like our gloves, are there opportunities to switch that out, have a more environmentally have gloves that have reduced environmental impact. Also think about the gowns. Again, not the highest component in weight, but it's been exciting because we've had the opportunity to do reusable gowns and, UCSF is spearheading that with different departments. And then to take the best practices of Stanford and say, we already know about this foam, let's start looking at the gel. And we're able to have discussions and realize that they were already using this in a lot of the PEDS procedures and how can we adapt that and bring that to our own department. Or look at something that's used all the time, like the foot pads and some of the chucks and think about switching those out. So it's helpful just to have, just to take a moment and have those pictures or have those conversations as a team. Really, even the conversations too have been very productive and helpful.
Thank you to our speakers. This has been a really exciting session. I mean, to see how the three of you have sort of taken a shoestring budget and really made a project that can make a difference.